Hello, my name is Meg Huang. I'm the Executive Director at the Center for Connected Health Policy, and today I'll be talking about state updates in relation to telehealth and COVID-19. Now, before we begin, just know that this is simply an overview of what's going on in the states. There have been many actions on the state level regarding telehealth policy in response to COVID-19, but this will give you an overview and also link you to resources where you can delve into it a little bit more deeper for your particular state. First off, I have to start with some disclaimers. Any information I provide today should only be considered for informational purposes. It is not legal advice. CCHP always recommends that if you are looking for a formal legal opinion that you seek out legal counsel. And also if I happen to mention a company or show a product, please know that neither I nor CCHP has any type of relationship or affiliation with such a company. Center for Connected Health Policy was established in 2009 and we're a program underneath the Public Health Institute. We became the federally designated National Telehealth Policy Resource Center in 2012, but we also work with a variety of funders and partners on very specific projects related to telehealth and connected health. To your right is actually a listing of some of the partners that we work with, both on a national and a regional scale. Some of the projects that we do at CCHP is a 50-state telehealth policy report. We are also the administrator for the National Consortium of Telehealth Resource Centers. And stemming from our work in California when we first established, we are also the convener for the California Telehealth Policy Coalition, which is an organization of over 70 statewide organizations interested in telehealth policy in the state. Working with the National Consortium TRCs, it is made up of 14 telehealth resource centers, 2 nationals, and 12 regional resource centers. The regional resource centers cover specific states, and the 2 nationals, one of which is CCHP, we cover policy, and the other one cover technology. We all work collaboratively together. I like to say if you reach out to one, you actually get 14 of us. But if you are interested in a particular state and interested in starting a telehealth program or have questions about your telehealth program or really just questions about telehealth in general, I say reach out to your telehealth resource center. So today I want to talk about the state of telehealth in COVID-19 on the state level. We have recorded other videos regarding Medicare and what's been going on the federal level, so please check those out. This one will focus, as I said, on states, and it will be pretty high level because each state really does things differently, and that was true even before COVID-19 hit. So in Medicaid, which is actually a lot of the telehealth policies for the state, for the fee-for-service side, pre-COVID-19, you actually had all the states doing something in telehealth in their Medicaid programs. Primarily, they were reimbursing for something in live video, and it ranged on what they did. So it could be something very narrow, as in just reimbursing for telemental or behavioral health in Medicaid if it was done via live video, to more expansive policies that would cover like maybe all modalities or like many more services. But there were usually a lot of limitations and caveats in the Medicaid programs. As you can see, Storm Forward and remote patient monitoring not as popular as far as the modality being reimbursed in Medicaid pre-COVID-19. States also had telehealth laws related to health insurers and how they were supposed to address telehealth and what they were supposed to cover. And again, it was a wide range of like what the policies were. So you have anywhere from states at one end saying that health plans, you may cover services delivered via telehealth, but it's really up to you to decide that, all the way to health plans, you shall cover services if it was delivered via telehealth. And by the way, you're going to pay the same amount as you would have paid had the service been provided in person. And then all the other states kind of fell in between there. So again, wide-ranging differences in policies between states pre-COVID-19. And here is actually a snapshot of our website. We actually do track all of those policies on the state level for all 50 states and the District of Columbia. We put that into the report that I showed earlier, but we also put the information up on our website and it's publicly accessible. That is an interactive map we have on our website. If you click on a particular state, it'll bring up the information and we've organized it by specific categories there. The information right now as of April 9th is good through October 2019. As you can imagine, it's a pretty laborious process. So we do 2 updates in the spring and the fall. We were actually in the midst of our spring update when COVID-19 broke. So we're trying to finish up that work. So we will have the spring update up in probably a couple of weeks. The information though is only really good for February 2020, so it will not include the emergency regulations. We do have that on a separate location on our website, so you might have to do a little bit of cross-referencing there on like, this is what their policies were pre-COVID-19, but they've expanded them with these emergency orders to address COVID-19. So that should be available in a couple of weeks. So what is going on in the COVID-19 world regarding telehealth policy in the states? So if you look at all of the actions taken by the states, you see a couple of common themes emerging that were pretty logical things to make changes for. So the big one is that they're allowing the home to be an eligible originating site, which makes complete sense in this particular environment because we're asking people to stay at home, or if they are suspected of having COVID-19, to self-quarantine. So you still want to try to get those services to the people who are not as seriously impacted if they are suspected of having COVID-19, or you want to monitor to see if maybe they do have COVID-19. So you want some way to get in touch with them or to monitor them, and telehealth is the perfect way to do that. You also want people who don't have COVID-19 or are suspected of having it to not come into hospitals and clinics and doctors' offices if they really don't have to. If you can like take care of them via telehealth. That's to, again, because we have stay-at-home orders, but to reduce the level of possible exposure, especially if they're going to places where there's probably like a high level of possibility of being exposed, such as a hospital. So allowing the home to be an eligible originating site, really sort of no-brainer policy to at least do a change for. And actually quite a few states had to do that. So what a lot of states had for their telehealth policies pre-COVID-19, not really a lot of states had like the home to be an eligible originating site, or if they did, they had it very restricted. They had a lot of caveats to it, like, oh, we would only allow the home to be originating site if somebody had a chronic condition that we were monitoring. And because now we're in this COVID-19 world, there's so many more things that you can do now that we want to do with people staying at home. So they had to expand the home to be an eligible originating sites, and actually quite a few states took those action. The second thing as a common sort of change that we're seeing is allowing telephone to be used to provide services. Now, again, pre-COVID-19, a lot, if not all, I'm trying to think, but most states, the majority of states, they had a specific definition of what telehealth or telemedicine, depending on what term they were using, meant. And practically all of those definitions explicitly excluded telephone. There were a couple that kind of included it or were broad enough to include it, but for the most part, most states said telephone does not actually count as telehealth or / telemedicine. So what you'll see with a lot of executive orders is that they're saying that we'll expand telehealth services and telephonic services. They'll specifically call out telephone. They have to, because if they just said telehealth, it wouldn't include the phone. Again, a logical move, because not everybody has access to the technology. Maybe all they have is like audio only phone. So that was like another sort of understandable move of why policymakers made that step and allowing that to be a way of like providing services. Then another common thing that we're seeing is like directions to health plans and how they approach telehealth. I mentioned that there were quite a few states, practically all states, about 4/5 of them had some type of telehealth health care or health plan law on the books already, but they were like wide ranging. So again, we're seeing specific executive orders or issue guidances from departments saying like, plans, this is how you're going to treat telehealth, or this is what you're going to do for telehealth when we're during this crisis. And these are a bit of a mixed bag as well. So you have them, some of the orders saying that where health plans, remember your obligations underneath their law, and like, make enrollees aware that these are options for you to, like, more explicit orders of health plans, like you're gonna, during this crisis, when this public health emergency order is in place, you are going to be covering services delivered by telehealth if the provider can provide them. So that is one thing that we're seeing commonly. An interesting thing with that, and some executive orders have covered this, is even pre-COVID-19, there were some questions with health plans meeting the requirements of telehealth coverage laws in their state, in that they would do that by contracting with a third-party vendor to provide all their telehealth services and not necessarily allowing their in-network providers to use telehealth to provide services. And that was kind of problematic because, for one thing, you're telling like an enrollee saying like you can't see your regular doctor, Dr. Smith, who's willing to use telehealth. You have to go to this company we have a contract with and meet this doctor you haven't met before and see them by telehealth, and that's the only way we'll cover it. That has also become a bit of an issue too during this COVID-19 world, and they're realizing that some insurers are doing that. Not all, but some insurers are doing that. So you might see in some of the executive orders saying like, and by the way, health plans, you need to allow your in-network providers to use telehealth if they can to provide services, or the enrollee needs to have or has the right to still see like their regular provider, the one that they've established a relationship with. So there's still some of those issues that are lingering there that they're trying to work out and trying to clear up as well. And also I do want to say, I don't want to paint health plans with a bad brush or anything. Some of them have really stepped up during this crisis where telehealth is concerned. Like for example, in like Montana, there was like no specific order to them on doing something with telehealth. The health plans there in Montana just agreed to do specific things regarding telehealth. So a lot of health plans are also just saying like, we're just going to cover it, it'll be fine. But there are some other issues that we've heard from enrollees or providers that they've run into, and that no, they're just saying like it's only going through this contracted provider company that they have. A couple of less common policy changes we're seeing in this emergency situation, but we're still seeing is beyond phone, there are actually not a lot of policy changes on expanding the modalities. It's really just been live video or phone, and live video was already currently existing in a lot of places. But we don't see like a lot of sweeping changes to saying like it's all modalities of telehealth. So it could be like implied in a lot of places because they may have just used the term telehealth, but no explicitness of saying like, you can use more store and forward, you can use more remote patient monitoring. So that it's happened in some places, but it's been like a little less common. Expanding the list of eligible providers. So actually pre-COVID-19, a lot of times definitely with Medicaid programs, and we've seen it with Medicare, they actually have a list of specific providers who are eligible to provide services via telehealth and will get reimbursed. And a lot of times they leave out the allied health professionals. We are seeing more states recognizing that because, hey, you probably don't want that person who needs that physical therapist to like still continue to go and meet with that physical therapist at their office. You want to try to do that at home with them because you still want them to receive that service to help them in whatever they're recovering from. But maybe you can do that over telehealth. So there are some states recognizing like we need to expand the list of like who can be an eligible provider, provide services via telehealth. But not as many states are doing it, or we're not seeing as many states who have done that as they would have said, like we're allowing phone to be a modality. And then waiving consent requirements. So actually the majority of states had some sort of consent requirement on the books or within their policies of saying like you need to get like consent signed or verbal or something like that before you provide telehealth services. They're not necessarily waiving them as much as like relaxing them or adjusting them. Sort of like, if they had a written consent requirement, then they would say like, it's fine if you get a verbal, just make sure you record it in the medical record. So they've been sort of adjusting these these consent requirements as well too. Now, again, how much states had to do in the COVID-19 or how many changes they had to make in reaction to COVID-19 to their telehealth policies really depended on where they were before COVID-19, because some states had to take more actions or have more broader policies than other states simply because those other states pre-COVID-19 had pretty broad policies to begin with. So they didn't have to do as many changes. And here are two examples. So California, literally a couple of months before COVID-19 hit, had updated their telehealth policies and Medicaid. So they had really greatly expanded. Like, for example, they allowed live video and store and forward to be provided for any service that they covered under the Medicaid program, as long as certain conditions were met, such as it didn't require an in-person element and could be done over telehealth, that type of thing. They also had no limitations on originating sites, so the home was already included. They also allowed community health centers to use telehealth, the live video portion of it, and then allow them for some store and forward as well. They did have like a private payer law that actually got a little bit more prescriptive. The legislation was actually passed last year to make it a little bit more clear and explicit to health plans on their coverage of telehealth, but that was not going to kick in until 2021. So in response to COVID-19, so what they have done have actually been, a little bit more of those other issues, addressing those other issues that you run into when you try to use telehealth. So just like the privacy laws, that, if you want to use it a little bit more expansively or something, and maybe you like run up against like a privacy protection law that might make you hesitate, they're relaxing some of those barriers because they took care of a lot of things beforehand. They just happened to have been in a better position before COVID-19 hit as far as where their telehealth policies were. Compare that to like Louisiana, which had like telehealth policies. They were using live video. They allowed some remote patient monitoring, like telecare. Hospices could do some of their social work reporting over the phone, but they didn't have like an expansive phone allowance, and there was a private payer law. So some of the changes they had to make was they allowed telephone to be used. They made it clear the patient could receive services in the home, because it was a little like unclear before, because they were saying like it was only for this telecare, which was more of a had very specific limitations of what they're doing. So they made clear on that, expanded that, and then they also, again, the whole issue of like who's an eligible provider to provide services telehealth. It was again not very clear pre-COVID-19. They made it a lot clearer though when they were during COVID-19 when they're in their response to it. So what are other things that we are encountering with all these rapid policy changes, because it is almost changing on a daily basis? If you look at all the states in totality, there's always a state doing something or another, because you do, once you change a telehealth policy, you sometimes do run into like an issue you hadn't thought of, like, oh, maybe the privacy issue, oh, maybe the consent issue, and then you got to do something else to address it. One of the problems is it's difficult to institute quickly. I mean, you are asking a lot of large organizations to really pivot quickly, like a health plan to pivot quickly to like do something. Maybe a health plan has agreed we're going to do X for telehealth, but is that information filtered down quickly enough to the staff who are actually processing the claims? So even things like that can take some time for it. And even though it may feel like we've been in this for so long, it's only been a couple of weeks, so it's a little hard for some of these institutions to like really pivot and change quickly with these new policies in place. I talked about it earlier about like payers having a contract with a third-party vendor to provide all their telehealth services. That has been an issue that has been raised. Some of the states have been addressing it by saying like, no, you need to like let your in-network providers use telehealth. You need to pay them, by the way, what they're contracted to pay for. And then another sort of issue is awareness that these policy changes have happened. Not only sometimes maybe for providers, because they are happening so quickly, it can get confusing for providers, but what about the consumers? Do they know this option is available to them? Where do they get most of their information? How is the information being distributed to them? So educating the consumer, saying like, this is an option for you now. You don't need to go into your doctor's office, try to do this, try to stay safe as possible. How is that being imparted to the consumers? How are they being educated that they have this option now? Probably health plans are trying to send that information out to their enrollees, but how is that being absorbed by the consumer? How are they just being told that this is now something that they can use to try to keep as safe as possible? 1135 waivers are other things related to the states that what they're doing, and I'll be frank and honest, I haven't had a chance to go through every single 1135 waiver, but of the ones that I have read, a lot of probably what they requested as far as like allowing to waive may have been addressed, or may not have required a waiver, because as far as like the Medicaid programs, there's actually quite a bit of leeway states have that don't require like a waiver of some sort. So one thing that they have addressed is, again, one of those issues that you may not have thought of immediately, but does crop up when you're saying like we want to use more telehealth, but also states might be facing like provider shortages. So they may, within the state, so they may need to go and like have out-of-state providers provide services. But if you're in the Medicaid program, you actually need to be enrolled in the Medicaid program before you can get reimbursed. So states are asking like, can we have that waived, because we need to like get these out-of-state providers in to provide services to our people who are on Medicaid, and CMS has been allowing those waivers to happen. We're starting to see pieces of state legislation related to COVID-19 come out. Those are a couple of states have already introduced things. Again, We do have like a special tracking on that. If you go to our legislation tracking page for on CCHP's website, you'll see like we have a special category there for coronavirus, so that will come up and you can see like what states have introduced. A couple things that they've introduced, like it's a regulation, is like broadening some of the rules to accommodate new services, or making sure that it's available like during a state of emergency, which is really interesting. Pre-COVID-19, actually practically all states, there were like a couple exceptions, but most states did not have anything related specifically to telehealth in an emergency situation. And I'm not saying like, a single emergency for a single person, but like when a declaration of a state of emergency has been declared, nobody really had anything on the books on that. California was one of the few that did, because of the fires that we had 2 years ago. So the legislation was in reaction to that. But a lot of states really didn't have anything related to use of telehealth in a state of emergency. So I would not be surprised if we see more of that cropping up. New Jersey is just one of the first states to introduce that. So here are some links to our website that can be resources for you. So for federal policies, we do track that, as well as like what's going on with the states. You can dig a little bit deeper. Again, I was just giving you an overview, but you can dig in a little deeper onto what each state is doing. If folks see that list and they see something is missing, please email us. We're more than happy to like, take that information. So if you see something that's happened in your states related to telehealth, like an executive order or something that's not listed on our website, please feel free to like send that on to us. And that is it. So thank you very much for attending this webinar. I hope you found it useful, and I hope you all stay safe. Thank you.